Picture this. A woman is 68 years old. Retired nurse. Walks 2 miles every morning. Manages her own medications, her own calendar, her own life. Her daughter convinces her to get a full workup at a new clinic. You have not had a full panel in a while, Mom. Let us just be thorough. The doctor looks at the numbers and says those 7 words that set everything in motion. Your kidney function looks a little off. 6 months later, that same woman is on a restricted diet that has taken the joy out of every meal. She is attending nephrology appointments every 8 weeks. She is managing anxiety about a condition her doctor described as early stage but serious enough to monitor closely. And the version of her life she had before that appointment, the morning walks, the easy travel, the sense of her body as something she could trust, that version is gone. She never had symptoms. She never had a crisis. She had a number on a lab report. And that number became her identity. That story is not rare. That story has a name in the medical literature. And today we are going to talk about it honestly. Before I begin, if you're interested in this topic, type interested in the comments and don't forget to subscribe. The goal is to hit 200,000 subscribers, and every single person who joins moves us closer. If you want my free kidney warning signs checklist, type the words kidney checklist in the comments right now and I will send you the download link personally. Completely free. Just 2 words, kidney checklist. Drop it below and let us get started. I work specifically at the intersection of kidney health and aging. And what I focus on is how the kidneys change after 60, what those changes actually mean, and critically, what they do not mean, and how the decisions we make around kidney screening in older adults can either protect quality of life or quietly dismantle it. In my years working with adults over 65, the pattern I keep seeing is this. People who felt completely fine before a routine workup and came out the other side managing a diagnosis, a label, a cascade of follow-ups that started from a place of feeling well. That pattern has a mechanism. It has a name. And once you understand it, you will never sit across from a doctor reviewing your kidney labs the same way again. Here is the number that should stop you cold. Studies estimate that between 15 and 25% of all medical interventions in the United States every year are unnecessary. But here is the part nobody says out loud. In adults over 65, that percentage climbs sharply. Not because older patients are sicker. Because the risk-to-benefit math changes completely after 65. And the kidney is where that math gets complicated in ways that most routine appointments are not equipped to handle. There is something called the cascade effect. It works like this. One routine lab panel shows a slightly low kidney function number. That number triggers a referral to a nephrologist. The nephrologist orders imaging. The imaging finds a small abnormality. The abnormality leads to a biopsy. The biopsy leads to a medication change. The medication causes a side effect that requires its own management. And a person who walked in feeling completely well is now carrying a diagnosis, a specialist, a restricted diet, and a level of medical anxiety they did not have before they agreed to a test. The cascade does not start with the biopsy. It starts with the first lab result. And that is exactly what today is about. I am going to walk you through 5 specific kidney-related checkups and screenings I would personally reconsider after age 65. Not because kidney health does not matter. It matters enormously. But because after 65, the kidneys age in predictable, well-documented ways that the screening system was not designed to account for. And the gap between what a test finds and what that finding actually means for your life is wider in kidney medicine than almost anywhere else. I will show you why that gap exists. What I have seen happen to real patients. And I will give you a set of specific questions at the end that will completely change the conversation at your next lab review. Stay with me through all 5. Number 3 is the one that surprises people most because it involves a test ordered so routinely most people do not even know it is happening. And number 1, the final one, is the screening almost nobody is questioning, even though the downstream consequences of acting on it in older adults are more serious than almost anything else on this list. Before we begin, drop your city or state in the comments right now. I read every single one of them and I genuinely want to know where you are watching from. But first, one concept. Because without it, nothing else I say today will fully land. I call it the longevity lens. Here is how it works. When you are 50, catching a kidney problem early is one of the most valuable investments you can make in your long-term health. You find a problem, you intervene, and you potentially protect your kidney function for the next 3 decades. The math is clean. After 65, 3 things change that math fundamentally. First, kidney function naturally declines with age in a way that is normal, expected, and in most cases completely harmless. Research consistently shows that GFR, the number used to measure kidney filtration, declines by roughly 1% per year after age 40 as a normal part of aging. By age 70, a person with no kidney disease at all often has numbers that look alarming when compared against reference ranges designed for a 40-year-old. Those numbers are not disease. They are biology. But the screening system does not always distinguish between the two. Second, the interventions triggered by kidney findings in older adults carry real risks. Contrast dyes used in kidney imaging can themselves damage kidney function, a condition called contrast-induced nephropathy. Biopsies carry bleeding risk that increases with age. Medications used to slow kidney decline can cause dangerous electrolyte imbalances in older bodies. Third, the cascade. One number. One referral. One chain of events that carried its own momentum from a starting point of feeling fine. Keep the longevity lens in mind through every item on this list. All right. Let us get into it. Checkup number 5. Routine microalbumin urine testing in older adults with stable, well-controlled diabetes and no symptoms. This one requires precision because it is easy to misread. I am not saying diabetic kidney monitoring has no value. In younger diabetic patients, tracking microalbumin in the urine, which are small amounts of protein that signal early kidney stress, is genuinely important and can change a trajectory. I am saying that for adults over 70 with stable, well-managed diabetes, no symptoms, and no trend of worsening numbers, routine microalbumin screening can trigger a chain of events whose risks are not well matched to the likely benefit. Here is the core issue. Microalbumin levels fluctuate significantly in older adults. Exercise within 24 hours of the test, a recent urinary tract infection, fever, physical stress, even a poor night of sleep can temporarily elevate the result. In a younger patient, a single elevated microalbumin typically prompts a repeat test and careful observation. In many clinical settings, a single elevated result in an older adult becomes immediate escalation. Additional medications are added. Dietary protein restrictions are tightened. Nephrology referrals are placed. And a patient who was managing their diabetes well and living a full life suddenly carries a new label and a new layer of medical complexity that may bear no relationship to what is actually happening in their kidneys. The intervention that most commonly follows, typically the addition or dose escalation of ACE inhibitors or ARBs to protect the kidneys, is clinically proven to lower blood pressure. And in older adults, a meaningful drop in blood pressure on standing, a condition called orthostatic hypotension, increases fall risk significantly. The medication meant to protect the kidneys can take away the stability the person had on their feet. I want to tell you about Walter. Walter is 72 years old, a retired accountant from Charlotte, North Carolina. Type 2 diabetic for 11 years, well controlled on a stable regimen, no symptoms, walking daily, fully independent. A routine urine test at his annual physical showed a slightly elevated microalbumin. His primary care physician escalated his ARB dose to protect his kidneys. Within 6 weeks, Walter was experiencing significant dizziness when standing. He caught himself on the kitchen counter once. He caught himself on the car door once. The third time, he did not catch himself. He fractured his wrist in a fall. His recovery took 4 months and permanently changed how he used his dominant hand. When he came to see me after that fall, he said, "All of this started because of a urine test I did not even know I was having." That sentence is not rare. It shows up in the records of older adults across the country with a consistency that should give every diabetic patient over 70 pause before accepting automatic escalation based on a single lab value. What to do instead? If you have stable diabetes, well-controlled numbers, and no symptoms of kidney involvement, ask your doctor these 3 things before any medication is changed. First, was this microalbumin result confirmed on a repeat test? Because clinical guidelines from the American Diabetes Association specifically recommend confirming an elevated result on 2 out of 3 samples over a 3 to 6 month period before acting on it. Second, does the proposed medication change carry a fall risk given my current blood pressure baseline? Third, what does careful monitoring without immediate escalation look like for someone my age and health status? Those 3 questions alone can protect you from a cascade that started from one fluctuating number, not a symptom. If you found that important, type the word protect in the comments right now. It tells me you are following this closely and it helps this channel reach the people who need this conversation most. Checkup number 4. Routine renal artery Doppler ultrasound in asymptomatic older adults with mildly elevated blood pressure. Before anyone closes this video, I want to be precise. Renal artery stenosis, the narrowing of the arteries supplying blood to the kidneys, is a real condition. In the right patient, with the right clinical picture, diagnosing and treating it matters. What I am questioning is the routine use of this imaging in older adults who have mildly elevated blood pressure and no other clinical indicators pointing toward this diagnosis. A renal artery Doppler is non-invasive as a standalone test. The problem is what it reliably finds in older adult arteries and what medicine does next. Atherosclerosis, the gradual buildup of plaque in blood vessel walls, is extremely common after age 65. Some degree of narrowing in the renal arteries is frequently present in older adults, often stable, often there for years, and in many cases never causing problems. When routine imaging finds it, the finding does not stay in a drawer. It generates a referral. It generates further imaging, often with iodinated contrast dye. And the primary treatment for significant renal artery stenosis, a procedure called percutaneous transluminal renal angioplasty sometimes with stenting, has been studied rigorously. The CORAL trial, a major multicenter randomized controlled trial published in the New England Journal of Medicine in 2014, found that renal artery stenting added to medical therapy did not reduce the risk of cardiovascular or kidney events compared to optimized medical therapy alone in patients with atherosclerotic renal artery stenosis. The procedure carried risks including contrast-induced nephropathy, the kidney damage caused directly by the dye used during imaging, bleeding at the access site, and in some cases arterial injury. In older adults whose kidneys were functioning adequately before imaging began, the contrast dye required for the workup can itself initiate a measurable decline in kidney function, creating the very problem the screening was meant to prevent. What to do instead? Before agreeing to a renal artery Doppler, ask your doctor these 3 things. First, beyond mildly elevated blood pressure, what specific clinical sign makes renal artery disease likely in my case? Because stable pressure that responds to medication is generally not a sufficient indicator on its own. Second, if the Doppler finds narrowing, what would the next step be, and does that next step involve contrast dye or a procedure that carries its own kidney risk? Third, what would optimized medical management of my blood pressure look like without imaging, and what outcomes can I realistically expect from that approach? Optimized blood pressure control through established medications and consistent lifestyle management protects your kidneys and your cardiovascular system with a far better risk profile than a procedural pathway in an asymptomatic older adult. If this point changed how you think about routine vascular imaging, type the word lens in the comments right now. Checkup number 3. Routine GFR-based chronic kidney disease staging in older adults with age-appropriate kidney function decline. This is the one that surprises people most. GFR, glomerular filtration rate, appears on almost every standard metabolic panel. It is calculated automatically from the creatinine in your blood along with your age and sex, and it appears on the printout whether anyone ordered it specifically or not. Most patients never know it is being tracked until a doctor looks at the printout and says your kidney number is a little low. Here is the problem that almost nobody explains clearly in that appointment. The GFR reference ranges currently used to stage chronic kidney disease were developed based on populations that skewed younger. A GFR below 60 in a 35-year-old is a genuine warning sign that requires investigation. A GFR of 56 in a 72-year-old may represent nothing more than the entirely predictable, biologically normal decline that comes with aging. The kidneys at 72 are not the kidneys at 35. They are smaller. They have fewer functioning nephrons. They filter blood more slowly. This is not disease. This is the organ aging. But the lab report does not know that. It flags the number. The flag generates a conversation. And in many cases, a conversation generates a diagnosis. And a person aging normally leaves that appointment as a stage 3 chronic kidney disease patient, a label that carries psychological weight, dietary restrictions, specialist referrals, and a framework for interpreting their own body that may bear no relationship to their actual clinical trajectory. A landmark analysis published in JAMA Internal Medicine found that applying age-specific GFR thresholds, meaning evaluating a 70-year-old's kidney function against what is normal for a 70-year-old rather than against a population-wide average, reclassified a substantial proportion of older adults out of the CKD category entirely. They did not have kidney disease. They had kidneys that were aging normally. But once the label is in the chart, it shapes every subsequent prescribing decision. It informs how every new provider reads that patient's record. It follows them for the rest of their medical life. I want to tell you about Patricia. Patricia is 69 years old, a retired librarian from Denver, Colorado. No symptoms, no history of kidney problems, no diabetes, no significant cardiovascular history. A standard metabolic panel at her annual physical returned a GFR of 56. Her doctor told her she had stage 3 chronic kidney disease and referred her immediately to nephrology. She was instructed to restrict dietary protein. She was told to avoid NSAIDs and a broad list of other medications. She was scheduled for nephrology follow-up every 3 months. By the time she came to see me, she had lost significant weight from dietary restriction, was avoiding social events where she could not control her food choices, and had developed serious anxiety about kidney failure. When I reviewed her full history with age-appropriate context and confirmed her kidney function had been stable over time with no downward trend, her numbers were consistent with normal aging for a woman of 69 with her background. She did not have progressive kidney disease. She had a number that had been interpreted without the longevity lens. What to ask when a GFR comes back flagged? Ask your doctor these 3 things before that number becomes a diagnosis. First, is my GFR result being compared against age-specific reference ranges or against a population-wide standard that includes people decades younger than me, because those 2 comparisons can produce completely different conclusions from the same number. Second, has my kidney function been trending downward consistently over multiple tests, or is this a single reading that may represent my stable age-appropriate baseline, because a declining trajectory and a stable low normal reading are completely different clinical situations? Third, if I do carry a CKD label, what specific restrictions or treatments follow from that label, and are those restrictions supported by evidence in someone with my stable pattern rather than in someone with progressive disease? A stable age-appropriate GFR is information. It is not a sentence. And that distinction deserves to be made out loud in the appointment room. Type the word truth in the comments right now if this is something you or someone you know needed to hear. Checkup number 2. Routine kidney ultrasound ordered specifically for incidental cyst surveillance in asymptomatic older adults. Almost nobody is questioning this one, and based on what the data consistently shows, that silence has real consequences for older adults receiving routine abdominal imaging year after year. A kidney ultrasound is non-invasive. Nothing enters the body. And that low barrier makes it one of the most frequently ordered imaging tests in older adults during annual workups or as part of broader screening panels. The problem is not the test in isolation. The problem is what it reliably finds in aging kidneys and what the clinical system does next. By age 70, simple kidney cysts are present in approximately 40 to 50% of adults. This figure comes from multiple large imaging studies and is well established in the nephrology literature. Simple cysts in older adults are overwhelmingly benign. They develop as part of normal kidney aging, do not cause symptoms, do not threaten kidney function, and in the vast majority of cases would never cause harm regardless of how long they are left alone. When they appear on an ultrasound report, however, the report must describe them. The Bosniak classification system assigns kidney cysts a category from 1 to 4 based on imaging features. Category 1 and Category 2 are simple and minimally complex cysts considered benign, with guidelines generally recommending no further follow-up. The challenge is that in practice, the presence of any cyst generates a conversation. Patients are told there is something on the kidney. Anxiety follows. Repeat imaging is scheduled in 6 months. When repeat imaging shows any size change, including changes that fall within normal measurement variability between different ultrasound machines and technicians, it can be interpreted as growth, which then generates a urology referral. A biopsy recommendation may follow. Biopsy of a kidney cyst carries real risks including bleeding, infection, and injury to adjacent kidney tissue. And in older adults whose blood pressure medications include agents that affect clotting, the bleeding risk is meaningfully elevated. The surgery to remove a cyst that was never causing harm carries surgical and anesthetic risks that in adults over 70 are not trivial, including risks to remaining kidney function from the procedure itself. The cyst that prompted the entire cascade was almost certainly benign and would have remained that way. What to do instead? If imaging is performed for another clinical reason and a cyst is found incidentally, ask your doctor these 3 things before any follow-up is scheduled. First, what Bosniak category is this cyst? Because Category 1 and most Category 2 cysts are considered benign by current urological guidelines and typically require no follow-up imaging at all. Second, what is the realistic probability that this specific cyst represents something requiring treatment in a person my age with no symptoms? Because in most cases the honest answer is very low and you deserve to hear that number before the cascade begins. Third, if follow-up imaging is being recommended, what specific change on that follow-up scan would actually alter management? Because if the answer is unclear, that is important information about whether the follow-up is driven by evidence or by the reflexive momentum of finding something on a report. Type the word aware in the comments right now if this is something you had not heard before. Checkup number 1. Routine kidney biopsy pursued for mildly abnormal labs in older adults with no symptoms and no evidence of rapid decline. This is the one. The one that most people have never heard challenged because a biopsy sounds like the definitive answer. When the kidneys are showing abnormal numbers, you biopsy them to find out exactly what is happening. The logic sounds airtight. But the data for adults over 70 with mildly abnormal labs, stable or slowly changing function over time, and no symptoms tells a story that most patients sitting across from a nephrologist are never fully told. A kidney biopsy is invasive. A large bore needle is guided by ultrasound through the skin of the lower back into the kidney to extract a small cylinder of tissue. In younger adults with rapidly worsening kidney function, significant protein or blood in the urine, or suspected inflammatory kidney diseases such as glomerulonephritis or vasculitis, a biopsy can be transformative. It identifies the exact mechanism of injury and guides immunosuppressive or targeted treatment that would otherwise be impossible to prescribe accurately. That is the biopsy that changes lives. In older adults with mild, stable lab abnormalities and no clinical urgency, the calculation is fundamentally different. Published data on kidney biopsy complications consistently shows rates of clinically significant bleeding in approximately 1 to 3% of cases, with blood transfusion required in roughly 1%. In older adults on antihypertensive medications, those with any degree of vascular fragility, or those on anticoagulants for conditions like atrial fibrillation, that bleeding risk is higher. There is also the question of diagnostic yield, meaning what the biopsy actually returns in this population. A kidney biopsy in a 74-year-old with mild, stable kidney function decline and no specific clinical indicators frequently returns a result of hypertensive nephrosclerosis or age-related nephrosclerosis, the progressive fibrosis and vascular thickening in kidney tissue that occurs predictably with aging and long-term blood pressure changes. It is not a condition with a specific reversible treatment. There is no targeted therapy that reverses established nephrosclerosis. The biopsy confirmed what age and clinical history already predicted. And the patient went through an invasive procedure, absorbed real complication risk, and went through a recovery period to receive information that did not change management in any meaningful way. I want to tell you about Howard. Howard is 76 years old, a retired civil engineer from Sacramento, California. 3 years of stable, mildly reduced kidney function, no symptoms, no blood in the urine, no rapid worsening at any point. His nephrologist recommended a biopsy to characterize the underlying cause. Howard trusted the recommendation. During the biopsy, a significant bleed developed that required hospitalization and ultimately a transfusion. He spent 4 days admitted. His measured kidney function after the procedure was lower than before it. The biopsy results showed age-related nephrosclerosis. There was no specific treatment to offer beyond what he was already doing. When Howard spoke with me after discharge, he said, "They went in to find out what was happening to my kidneys and came out with less kidney than I had going in." That sentence captures a failure of the risk-to-benefit calculation that the longevity lens, had anyone applied it consistently in that appointment, should have caught before the procedure was ever scheduled. What to ask before agreeing to a biopsy. Ask your doctor these 3 things before that needle is ever scheduled. First, what specific clinical decision will change based on the biopsy result, and if the treatment plan is likely to be the same whether the biopsy shows age-related scarring or another slow-moving process that tells you something critical about whether the procedure is being done for you or for the chart. Second, what is my personal complication risk for this procedure given my age, my current medications, my blood pressure history, and my vascular health, because the published average complication rate and your individual risk are not the same number and you deserve to know yours. Third, what would watchful monitoring with repeat labs every 3 to 6 months show over time, and is there a clinical threshold, a specific rate of decline or a new symptom, that would make a biopsy clearly warranted that we could watch for together? For many older adults with stable, slowly changing kidney function and no symptoms pointing to a specific treatable cause, monitoring is not inadequate care. It is the safer, more rational path. And any nephrologist who is genuinely in your corner will be able to tell you honestly whether your case is one where a biopsy changes management or one where it confirms what observation would show over time for far less risk. Type the word SHIELD in the comments right now if you want me to cover the medications most commonly prescribed for kidney protection in older adults and the risks that almost nobody is explaining at the pharmacy counter. Now let me pull everything together with the 5 questions I promised you at the start. Every time a doctor recommends a kidney-related screening test, lab follow-up, imaging study, or procedure, especially if you are over 65 and you feel well, have these 5 questions ready. Write them down right now. Put them in your phone. Bring them into every appointment. Question 1. What is the false positive rate or the age normal rate for this finding in someone my age? Kidney lab values and imaging findings in older adults carry a high rate of results that look like disease on a standard reference range but represent nothing more than normal aging. You deserve to know how likely you are to be chasing a normal finding before that chase begins. Question 2. If this test or result triggers a next step, what are the realistic treatment options for someone my specific age and health status, and do those treatments carry meaningful risks for someone with my profile? Do not let the conversation end at "we found something." Push it every time to "and then what, and what does that next step cost me?" Question 3. What is the complication risk of the procedure we would most likely pursue, specifically for someone my age, on my current medications, with my blood pressure and vascular history? Not the average patient in a published study. You. Biopsy, contrast imaging, vascular procedures, each carries a risk profile that shifts meaningfully after 65 and even more after 70. You deserve that specific number before you say yes. Question 4. What happens if we monitor carefully instead of intervening now? For stable, slowly progressing kidney findings in older adults, monitoring is not giving up on your health. It is refusing to launch a cascade from a place of feeling fine. It is the math done correctly. Any doctor who dismisses that question is not doing the math with you. Question 5. What is the most effective non-invasive approach for protecting my kidney function right now? Because as you have seen today across every item on this list, consistent blood pressure control, blood sugar management, adequate hydration, regular low-impact physical activity, and a careful medication review protect kidney function in older adults more meaningfully and with a fraction of the risk of any screening-triggered procedure currently being offered. Any physician who is genuinely working in your interest will welcome every one of those questions. They will not make you feel difficult for asking them. And if a doctor makes you feel like a problem patient for raising them, that is important information about whether that doctor is the right partner for your care at this stage of your life. Here is what I want you to do before your next appointment. Write those 5 questions on a card or put them in the Notes app on your phone right now, this hour. Bring that card into the room. You do not have to use all 5. You may only need 1. But having them in your hand changes how you show up. And how you show up changes what happens to your kidneys, your independence, and the life you are living right now. There is someone in your life, a spouse, a sibling, a parent, an adult child navigating annual physicals for someone they love, who needs to hear what we covered today before their next lab review. You do not have to explain it. You can just send them this video. If this conversation changed how you think about kidney health and routine care after 65, subscribe to this channel. Next week I am covering the specific medications routinely prescribed to older adults that carry a completely different risk profile for the kidneys after 65 than they do at 50, and what to ask your pharmacist before you refill them. If you are on more than 2 daily medications, that video was made for you. Leave a comment below. Have you ever had a routine kidney lab result or imaging finding lead somewhere you did not expect? Your story in that comments section might be exactly what someone else needs to read before they walk into their next appointment. Take care of yourselves. I will see you next week.